Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today we'll be discussing the connection between obesity and aging. According to data from the National Health and Nutrition Examination Survey taken from 2017 and 2018, more than 2 in 5 adults in the United States have obesity, and nearly 1 in 5 children and adolescents do as well. At the same time, the country's population is aging, with the number of Americans ages 65 and older expected to more than double over the next 40 years. Both obesity and aging are associated with many common chronic illnesses, including heart disease, high blood pressure, and diabetes. Today, we will explore why some physicians are drawing parallels between the two conditions, even calling obesity a form of premature aging. My guest is my colleague, Dr. Mitchell Roslin. Dr. Roslin is the Director of Bariatric Surgery at Northern Westchester Hospital of Northwell Health and a Professor of Surgery at the Zucker School of Medicine. Mitch, welcome to Well Said.
Thank you for having me, Ira. That was a great introduction. It really does take us down a whole bunch of different paths.
I was especially looking forward to this conversation. We're talking about two incredibly common circumstances, and it'll be interesting to draw some parallels between the two. But before we do, I just want to ask you, as I've become accustomed to asking all my guests, how have you been doing during these extraordinary times?
I really felt more fortunate to be a doctor and a surgeon during these times. And I know that may sound really strange, and so many of your friends walk up to you and say, wow, you guys must be being overwhelmed. I've kind of felt a little the opposite. I really feel fortunate that I've gotten to go to work, deal with residents, be in the operating room with medical students, interact with other people, and it's given me a perspective that I'm really, really fortunate. Like, I think that, talking about aging, that keeps me younger and keeps me vibrant. I think I've appreciated the operating room more as I've approached, my 59th to 60th year of life than ever before because of it.
So, Mitch, let's start by defining some terms. So I quoted some statistics in my intro about obesity and its prevalence in our society. And our listeners have probably heard the phrase obesity epidemic used to describe how many Americans are being classified as obese. So let's get some definitions out of the way. As an expert in obesity, 2 questions. How do you define obesity? And is there really an obesity epidemic?
The definition of obesity is actually excess adiposity. The problem is there's no great way or simple way of measuring fat tissue. You really need more complicated things. There are rough ways that are inconvenient, like measuring skin folds. So we tend to kind of use a definition of body mass index, which is a simplistic number that takes your weight and divides it by your height. If you do it in the metric system, which is usually done, it's your weight in kilograms divided by your height in meters squared. And essentially a body mass index of 30 is considered obese. And then that's class 1 obesity. Class 2 obesity is a body mass index of 35. Class 3 obesity would be a body mass index of 40. But we don't think in those terms, so let's put it into some sort of perspective. So class 3 obesity would be about a 5'3" per person who's 220 pounds. And then if you roughly would subtract 30 pounds, the same 60 pounds, 170 pound, 5'3" person would have a body mass index of approximately 30.
And you said that body mass index is not that great. It's sort of an approximation. Where does it fail, or why is that not a good way to think about this?
First of all, number one is sometimes people think that it correlates completely with health. And there's certainly no data that somebody with a body mass index of 29 is less healthy than a body mass index of 28. In fact, there may even be a survival advantage for people when normal body mass index is considered 25. There are people, for example, who are very muscular and will have a higher body mass index than that. And honestly, the more lean muscle mass you have, probably the healthier you're going to be in the long run. In terms of the second question that you asked about an epidemic of obesity, absolutely. Going back to when I was graduating from college, the Surgeon General was somebody by the name of Everett Koop. I don't know how many of our listeners will remember, but
I certainly do.
But so then you probably were entering or finishing med school about the same time as I was, and the last big viral issue that in our lifetime, the HIV epidemic was rising as I entered vet school in New York, and Everett Koop said, it's not HIV that's going to be our biggest health problem. It's going to be obesity and sedentary lifestyle. And he wrote a piece called Shape Up America, and at that time, the overall obesity percentage in the United States was about 10 to 15%. So I guess if we do the math from 1980 to now has been 40 years. In that time, we've seen practically a tripling in that number. And that's something that's really absolutely scary. And what's scary, even more scary, is that it's a bipolar distribution affecting more people in our lower socioeconomic groups and affecting, as you alluded to in the pediatric discussion, more younger and younger people, which means that more younger and younger people are going to have the chronic diseases associated with obesity, perhaps even before they even start their careers.
So before we get into the discussion about aging and obesity, you alluded to chronic illnesses that are associated with obesity, and you are concerned about the numbers of people who are obese in the United States. So just run that down for our listeners a little bit. Why is obesity a risk to health?
I like to think in terms of the M's. So let's start with the metabolic, which is what people think about. Number one, 80% of the people who are obese in the United States are insulin resistant. And the biggest cause now of infertility in young females and a major cause of impotence in males or low testosterone is obesity. In the female case, the high insulin rate impacts their ability to convert testosterone into estrogen. In male cases, the excess fat actually does the opposite, the testosterone, and this is also seen in women as they approach menopause. The testosterone is converted into estrogen. We have epidemic levels of type 2 diabetes. So as insulin resistance progresses, you lose the ability to control your glucose level. Another condition that's being seen, which used to only be associated with alcoholics, is non-alcoholic fatty liver disease. The liver is just such an essential organ, and we are seeing more steato or fat-induced hepatitis and fatty liver virtually in rates that are higher than the diabetes rate. So when you have high insulin, that's the biggest marker. So the liver is really adversely impacted. Obviously, everybody knows the link between obesity and high lipid levels causing heart disease. So the combination of high lipid levels, hypertension, as well as diabetes or high insulin levels really increases the risk for strokes and heart attacks, as well as atherosclerotic heart disease. So that's some of the metabolic impacts. So it goes from impotence to infertility all the way to heart disease and strokes. Now let's go to the mechanical, because not everybody who's obese has a severe metabolic disease. The mechanical impact is, there's tons of wear and tear on your joints. But not only that, obesity is an inflammatory disease, so there's increased levels of cartilage breakdown. Then another mechanical consequence is sleep apnea, tremendously undiagnosed. So what happens is the obesity in the upper airway actually obstructs your ability to breathe at night. And that limits the ability of getting a good night's sleep because you're always wakening up. And actually, when we're being awakened, that's one of the biggest reasons that when we do teenage cases, we see such an improvement in their school performance, because there's really an increased ability to be able to concentrate, also increased reflux disease. Now let's move over to the mental aspects of obesity. You can't hide obesity. There's been numerous studies that have shown that people would rather be dead or be disabled than be morbidly obese. And it seems preposterous at the very beginning, but most of your medical problems you can kind of keep private, but obesity is right out there for anybody to see.
How much of that is kind of a lack of acceptance as opposed to, meaning it's not the person with obesity's problem, it's the problem of the people around them?
There's no simple answer to the combination, but the perception. So I would argue that obesity is the last bastion of accepted prejudice. You only have to go back to the last Seinfeld episode. You could never do that with any other condition. I think, and this takes us to some of the other things that we're going to talk about, the perception that obese people just eat too much. I would begin to argue that obese people are forced to eat because of the breakdown in their control system, and we can talk more about that. So essentially, you have people being blamed for their own condition, and I think even people afflicted buy into it. So I don't think there's any one answer, and I think what we're really saying on things like Well Said is that we need to take care of the total person. We can't exist in these silos where we only take care of the liver, or we only take care of the reproductive organs, or we only take everything goes together, and that's what we're seeing right now, and potentially these are the things that we need to discuss more as we evolve in medicine from kind of the single etiology to the for the single disease.
You've painted a fairly bleak picture of the consequences of being significantly overweight. Do you not buy into the fat but fit kind of characterization that some people try to popularize?
What I would say to you, and that brings us into what I was trying to say, is what obesity does is it puts more miles on the speedometer in a single year. But if I asked you as the host of Well Said, and I said, what's the biggest risk factor for lung cancer? What's the biggest risk factor for dementia? What's the biggest risk factor for atherosclerotic heart disease? You may say for lung cancer, you may say smoking, but it's really not true. For atherosclerotic heart disease, you may say hypertension or hyperlipidemia or high apoprotein B, but that's really not true. And for dementia, probably most people would say age, but the answer for all of them is age. And what obesity does is it accelerates your aging pathway. So when we go back to where you started by asking me how I was doing in COVID, it was really, really interesting. Who was in our ICU? It was elder people and people who were more likely obese with metabolic disease. Does that mean that everybody who was obese died from COVID? Of course not. And this is one of the most difficult things in medicine is looking at causation rather than association. And that's what kind of, when going back to when we talk about cigarette smoking. So not everybody that smokes is going to die of lung cancer or get small vessel disease, but it increases your odds. And what I would argue is that obesity is a disease that impacts the way that we oxidize fuel in a place in the cells called the mitochondria, and then with time causes irreversible damage to this area, making it more difficult for it to treat.
So let's dive in a little bit deeper. Before we get to the cellular mechanism, make the case that obesity is like running the odometer at a higher rate. What's the connection between obesity and aging?
Again, let's look at, for example, something like dementia. We are now seeing earlier stages of dementia, and that seems to be related to the glucose pathway and the insulin growth factor pathway. When you look at any sort of longevity studies and you look at people who live a long life, they seem to be protected in two pathways, having protective effects against atherosclerotic heart disease and having protective effects at the insulin glucose, insulin growth factor, derived growth factor pathway. So those seem to be the two places where people are have protective benefits. So even if we look at things that we know are associated with survival, lower mean glucose, there have been numerous things talking about how in animal models, restrictive feeding or low caloric diets have been associated with longevity. The drug that's being studied most actively, especially at one of our sister hospitals, is metformin. Metformin has been shown, which has been mainly used as a diabetes drug, and shown that diabetics on metformin actually have a better survival than non-diabetics who are matched off the drug. And that's why metformin is being looked at as potentially a longevity drug. So clearly we're seeing, and most recently we've seen really tremendous links between obesity and cancer. Probably a lot to do with the fact that cancer cells actually mandatorily use glucose, so-called Warburg effect. And what's abundant, as we've been talking about, in diabetes and insulin resistance, glucose. So what we're seeing, I think, is that most diseases of aging that we kind of use a term, it's genetic, my parents had that, are probably more metabolic and are associated with higher turnover in the glucose-insulin pathway.
And do you see higher rates of cancer in obese individuals?
Oh, absolutely. Colon cancer, absolutely. Prostate cancer, breast cancer. And in fact, the lead article in JAMA last week was a review article done by the Cleveland Clinic showing that bariatric surgery actually reduces cancer deaths. Now, that's been seen in females, but now it's been seen in males as well. Females, because of the big incidence, the relationship between obesity and postmenopausal breast cancer.
Wow. You think the current thinking about the basis of this connection is at the level of cellular metabolism? Is that what you're saying, that there's more glucose circulating?
I think it's broad. So now when you talk about, for example, different hormonally active, all of your sex hormones are bound in fat, so you have different levels. Also, fatty tissue can convert testosterone to estrogen through what's called aromatase. So the link between the hormonally sensitive tumors like breast cancer are fairly obvious. Then you get into some of the other tumors like colon cancer, for example. Pancreatic cancer seem to be very, very much increased in obesity, and they probably are somewhat derived on the fact that insulin-derived growth factor creates such a favorable environment for cancer cells to grow. So I think more and more we're going to see cancer as not just a genetic disease or an oncogene disease, but as a metabolic disease.
I mean, I think it's also become more understood that our immune system is related to cancer. We did a show not long ago about harnessing patients' own immune system to fight cancer. Is there a connection between obesity, aging, and the immune system?
I would tend to believe there's a relationship between everything. There's no question that the way you look at the markers that people who are obese have, they more often have high C-reactive proteins. They more often have high SED rates.
C-reactive protein SED rates are markers of a kind of revved up immune system.
What's called interleukin levels, especially of some of the negative interleukins.
The immune system is revved up, you have more markers of inflammation. Okay.
Yes. So one way to think about obesity is kind of like a stable, constant inflammatory load. Like, our listeners may not be familiar with the term sepsis, which is when there's an infection in the blood system. So when that happens acutely, you get a cascade of events. We've evolved very well to handle short-term stress. Obesity seems to be like a constant long-term stress on the body. And that seems to be what is most the worst thing. If you look at, for example, exercise is a very short-term stress, and that's considered to be very, very positive. But if I told you about something that makes your heart rate really go high, it breaks down your creatine kinase, doesn't sound that healthy, but we all know that exercise is probably the most significant thing you can do for longevity. So short-term stress is great, but what obesity is a constant state of always having kind of the furnace on. And I think that's probably the best way I can explain it. The furnace is always on. There's higher turnover of glucose. Going back to what do our primary care doctors order when they're not sure whether a mass is malignant or not? They order a PET scan. What is a PET scan? A PET scan takes a radionucleotide that's bound to glucose and shows that the cancer cell is more likely to metabolize that. So it lights up. So you can begin to see how these things come together.
So you've made a case, a pretty compelling case, that obesity is not good for you over the long term, that it shares some of the same kind of propensity for chronic illness that aging does, and that there may be some deep connections between the two. Aging is something we have no control over. I mean, obviously, it's the lucky among us who get to age. But talk to me about obesity. You were talking about how people don't have the control over their weight that is often assumed to be the case. So what's the answer here? Where does their obesity come from, and how do we help them to deal with it?
Obesity itself is a marker that you're potentially don't have energy balance, and I think that will accelerate your aging. But I actually think, yes, part of things that are going to happen are predetermined. Certainly people that have lived to the longest age probably have some helpful genetic markers, but I'm really actually encouraged by what we do in bariatric surgery, that we've extended the longevity of patients, as we've talked about cancer survival, and we have matched controls that show lower deaths from heart disease, lower deaths from stroke. And that demonstrates to me that we do have a control over longevity, that if we are active, if we do eat appropriately, if we do watch our biomarkers, that we can at least maximize the cards that we're dealt. And I think that that's really one of the major points, that when you begin to look at this at a more metabolic level, you see the toxic reaction that's going on in your cells. And I think there are things that you can do now if you want to play with your grandchildren into your mid-80s. And I think that's probably what we've learned the most by doing bariatric surgery, is that many things are reversible, and there are also long-term consequences that are just better than dying of the diabetes and heart disease.
I think that's a point well taken, and I was not making the case that we have no control over how well we age, because I'm a big believer in all of those things that you just mentioned about maintaining a healthy lifestyle, levels of activity, mental engagement, social engagement, et cetera, et cetera. But you were making the case earlier that people don't have the control over their weight that is commonly assumed to be the case, right? That's where the stigma comes from, that people, they have no willpower, or they're eating excessively and it's their own fault. If we back away from that... So
it's a great question, what you just asked, which is the essential, which is fascinating. And this is the fascinating and one of the more difficult things to explain. So obesity is both genetic and epigenetic, and I'll explain what both of those mean. Interestingly, the original obesity investigators were all psychologists, and perhaps the most renowned of them all was a man by the name of Mickey Skunkert, who was a professor of psychology at the University of Pennsylvania. And he ran around the world, and he found all of the identical twins that were separated at birth and looked at what their weight and body composition was. And it had above a 90% concordance, which is nothing's 90% concordant.
Meaning that if identical twins were raised separately, they both ended up around the same weight.
Exactly. Okay. However, go back to where we started the podcast, which is what you asked me about an obesity epidemic. Well, it takes millions on millions and millions of years for our genes to change. So how do you begin to explain that? Our genes are wrapped in certain proteins that basically decide which of our genes are expressed. And the environment begins to turn those things on, even in utero. So we see the impact of the neonatal environment. And what's happened is our food sources, especially the processed foods, especially things that are high in fructose, are so different than ever before. And it's really, really important because things like fructose, a nutrient basically, to explain, is we can't get energy directly from the sun. So the sun basically works with plants that forms the carbon bonds and gives energy, and then we break those things down to get our energy. That's what a nutrient does, is it produces chemical energy for us. Actually, fructose, when it goes into the liver, actually causes energy to be drained from the system. And originally it was probably a protective effect to make us build up fat at the time of the harvest. But what's happening when all of this processed food is coming is it's giving the body a different message and telling the body to store, not break down fat, and actually causing damage in the cellular level that becomes irreversible.
So we're living in an environment that our genes are not well suited for.
We're living in an environment where our food sources are different than ever before. And I guess the first thing is to prevent obesity really means that we have to assess what our children and our young adults are eating. And that once this process is turned on, then it becomes really, really difficult to treat. And you're looking at things like surgery or a lifetime of medications. So you really want to halt the process. Again, I don't mean to make this like a hopeless endeavor. There's absolute data that kids that are exposed to less sugar absorb less sugar in life. We have to look at where our diets are in terms of how little fiber's in our diet. And again, no matter what the condition, nutrition matters. And what I tell all of my patients is I try to give them as fresh a start as possible, but I'm not operating on the Dorito, I'm operating on them. So I'm not going to make bad food healthier. And it's actually interesting because the psyche is not like that. You do weight loss surgery. No, I do eat less, eat different surgery, and hopefully weight loss and health is a side effect of that.
Yeah, that's really fascinating. Look, Mitch, we could go on like this for hours, but I think we're going to have to wrap this up soon. So are there some final thoughts or observations you'd like to share?
Being in this field for a long time, it's kind of ironic. It's like you think it's common sense. So what I would say is it's not simple accounting like the way we grew up, because if it was simple accounting, people wouldn't tell you I used to be able to eat everything and now I just look at food and I gain weight. Eating fat does not give you fatty liver. And what I've found really, really fascinating in some of the research that we've been doing is that obese patients are not able to actually burn fat. And I think that explains many of the things going on. So humans can either burn fat, carbohydrate, protein as fuel, and you would tend to think that people with excess fat could burn fat. But what happens is there's something going on which makes them only burn carbohydrate and begins to explain one of the big ironies, which I think we can spend a whole show on, which is why is exercise the most important thing to preventing weight regain, but sometimes when you exercise to lose weight, you just eat more? And the answer is because most of the time you're just burning glycogen or glucose, and you have to go to the bank to replenish the store. It's really a disease of irony. It seems so simple and everybody has an opinion, but it is much, much more complicated. It seems to involve every system in the body and all of our chronic health problems.
We'll have to have you back on the show to talk more about obesity and ways it starts and in ways we can address it. Thank you for sharing your insights about obesity and aging today.
Thank you for having me. I appreciate it.
My guest has been Dr. Mitchell Roslin. He is the Director of Bariatric Surgery at Northern Westchester Hospital and a Professor of Surgery at the Zucker School of Medicine. For more information about this program and to find past episodes, please visit medicine.hofstra.edu/wellsaid. You can also subscribe to our free podcast wherever you get your podcasts. podcast. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.